Good afternoon to everyone once again. Now I'm going to talk about something totally different, arterial stiffness and nephrolithiasis. Nephrolithiasis is recognized as multisystemic disease. As Gambaro and his colleagues said, it is actually a red flag for cardiovascular disease. With its peak incidence at around 40, it clinically presents 20 years after beginning of the metabolic syndrome and 20 years before myocardial infarction. So the episodes of lithiasis should be actually considered as a warning sign of an ongoing and silent atherosclerotic process. There are not many studies that examine directly relationship between nephrolithiasis and arterial stiffness, but here I present two of them. One is prospective study, which showed that patients with nephrolithiasis had higher systolic blood pressure, but also they had greater arterial stiffness, defined as carotid femoral pulse wave velocity, at the baseline and after the 10-year of follow-up. The next study is a Taiwanese population study, in which it was shown that kidney stone disease is associated with higher risk of increased arterial stiffness, but only in individuals aged more than 40, more than 50. As for now, there are no comprehensive meta-analyses directly examining this link. There are much more studies that examined relationship between nephrolithiasis and atherosclerotic disease. I not go through all of this that I showed, but I'll finish with this meta-analysis at the end, which included more than 4 million participants, and among them there was more than 200,000 patients with kidney stone. This meta-analysis showed that kidney stone formers have 25 higher risk of coronary artery disease, 70% higher risk of stroke, and even 39% higher risk of arterial disease. So obviously there's a link between arterial disease and nephrolithiasis. These proposed pathophysiological mechanisms include chronic inflammation, vascular calcification, oxidative stress and endothelial dysfunction, and also metabolic syndrome components. So now I will discuss two of them, actually. This is very interesting proposed mechanism that show us how calcium stone disease is associated with atherosclerotic cardiovascular disease. And we know that calcium stones are the most common type of kidney stones. As Ivan told us about atherosclerosis and hypercholesterol link, here this is one very interesting mechanism about how increased cholesterol ingestion can induce atherosclerosis and nephrolithiasis, but through totally different mechanisms. This is through oxalic acid metabolism. Increased ingestion of cholesterol leads to hyperoxaluria. This leads to calcium oxalate stone formation, not stone but crystal formation, and this is associated with increased osteopontin expression. This osteopontin expression then induce increased binding hydroxyapatite and calcium oxalate to endothelial cells in the kidney, but also in other parts of the body. This induce high oxidative stress and endothelial cell apoptosis. Then it induce inflammation, macrophage activation, and so on. And this all contributes to atherosclerosis in one side. And on the other side, in the kidney, it is induced ectopic calcification. You know, Randall plaques in kidney interstitium that is directly linked to endothelial cells, but also direct stone formation in kidney tubule on the luminal part of epithelial cells. So the second most common type of kidney stones are uric stones. Here they are strongly associated with metabolic syndrome, and here insulin resistance plays a central role. We can see on the left side of this picture how insulin resistance induces vascular remodeling. But what was interesting for me when I was preparing for this presentation is that insulin resistance induces high activity of xanthine oxidase, which then by itself induce vascular remodeling and also through hyperuricemia. And we know that hyperuricemia can induce hyperuricosuria and kidney stone formation, but also insulin resistance by decreasing urinary pH can contribute to uric acid precipitation even in the state of normal uricosuria. So instead of conclusion, I will conclude with this slide. How to manage patient with kidney stones. When we have patient with kidney stones, whether he is symptomatic or asymptomatic, we must evaluate him not only to find the etiology of kidney stone disease, to identify, we must identify metabolic and mineral disorders, but we also have to evaluate for the whole global cardiovascular risk and metabolic disorders in this patient to adopt adequate treatment and to actually to slow the kidney stone disease progression and kidney stone recurrence, and to slow the progression of chronic kidney disease, cardiovascular disease, and hypertension. So thank you for your attention.